So we're going to start the next presentation, and we're just so fortunate again to have such great keynote speakers today, and to really look at the issue of COVID from a really a developmental and lifespan perspective. In the morning we heard about youth, and now we're going to hear about older adults. And our guest speaker, again, excellent speaker, Dr. Linda Ma, and she's a senior clinician scientist at the Rotman Research Institute at Baycrest Health Sciences, and also an associate professor in psychiatry at University of Toronto. And she has a lot. I'm trying to even pick out of the many accomplishments which to highlight, but she completed her psychiatry residency at McGill and obtained subspecialty training in clinical neuropsychiatry in the US, followed by research fellowships in cognitive neuroscience, neuroimaging of mood disorders at the National Institutes of Health, master's in health science from Duke University, and for 3 years she served as a mentor in the diversity mentorship program in the Faculty of Medicine at U of T. And since the onset of the COVID-19 pandemic, Dr. Ma has served as a member of the Ontario COVID-19 Science Advisory Table. So she really brings a wealth of knowledge from that. She's giving guidance to the province and more recently appointed co-chair of the mental health working group for the Ontario COVID Science Advisory Table. So Dr. Ma's research focuses on advancing our understanding of the relationship between cognition and emotion in healthy aging and in disorders of older adults, and applying this knowledge to improve diagnostic and treatment of disorders associated with later life. She's published work on the role of emotional dysregulation, neuropsychiatric symptoms such as depression, anxiety as potential biomarkers of Alzheimer's disease, and on the efficacy of neurostimulation approaches to treat neuropsychiatric and cognitive symptoms in older adults at risk for developing Alzheimer's. So actually that touches so many of our research programs here in London. I know it'll be of interest. Her work as a principal investigator or co-investigator has been supported by the Alzheimer's Society, Brain Canada, Centre for Brain Innovation, and Ontario Ministry of Health Innovation Funds. Since 2019, she's been appointed as an associate editor for the Journal of Alzheimer's Disease. Dr. Ma has received several recognitions for her work and was recently selected as the inaugural recipient of the Baycrest Woman Scientist of Distinction Award. With the onset of COVID, Dr. Ma and her collaborators have been examining the effects of COVID-19 pandemic and physical distancing on the mental health of older adults with mood or memory concerns, as well as healthy older adults. Changes in mental health over the course of the pandemic, as well as the incidence of psychiatric illness and their impact on subjective and objective cognitive ability are being assessed. The study's findings will provide an understanding of the impact of COVID-19 pandemic on mental health in older adults, and in addition, allow public health officials to make informed decisions on how best to implement community-wide restrictions and to navigate the impact of future pandemics or other public health crises while minimizing mental health risks in older adults. So again, very warm welcome, Linda. You sound like the absolute perfect person to be speaking to us about these issues.
Thank you, Cheryl, for the introduction. And thank you everyone for coming to my talk. I'd like to thank Renee Hunt for inviting me to be a speaker today. I have a lot of content, so I'm just going to jump right into it. So I'm going to be talking today about older adults and the mental health effects of the COVID-19 pandemic, as well as past pandemics. I do want to do a preamble. So you could hear from my bio sketch that I'm actually not an epidemiologist, and my research focus pre-pandemic was really looking at risk factors and identifying novel biomarkers for Alzheimer's disease or AD. I have a long-standing interest in emotion regulation and neurocorrelates of emotion regulation. I'm involved in clinical trials of depression and Alzheimer's. et cetera, et cetera. So, but of course, with the COVID-19 pandemic, we've all had to pivot. And this is why I turned my attention to looking at mental health effects on older adults during the COVID-19 pandemic, partly for practical reasons, but also for scientific reasons. And I'll explain that later when I talk about the study that we're currently doing. Okay, so the learning objectives for today's talk. Number one, to be familiar with the literature on the impact of previous pandemics on older adults' mental health. Number two, to discuss the literature on mental health outcomes of older adults during the COVID-19 pandemic in Canada and globally. And then number three, to describe recent findings on changes in mental health in older adults over the course of the COVID-19 pandemic, and to look at their impact on subjective as well as objective cognitive ability. So I'll start with the first objective, to be familiar with the literature on previous pandemics on older adults' mental health. So this work, we did a literature review because, as I said, I'm not an epidemiologist, and I actually was not familiar with pandemics before the COVID-19. So we launched into looking at the existing literature. The work was done by two previous University of Toronto co-op students in my lab who were present with me during the onset of the pandemic. So Sylvia Beda, Umina Ahmed, and a research analyst, Stella Bay. So we all looked at literature. We were looking at mental health outcomes of any past pandemic. And we were trying to look for studies specifically in older adults to look at what are the rates of depression, stress, anxiety, and other psychiatric or psychological symptoms due to pandemics. We use these keywords, and you can see it was an extensive search. It was over 3 decades, considered pandemics involving SARS or severe acute respiratory syndrome, Middle East respiratory syndrome or MERS, H1N1, which is influenza, Ebola, and also H7N7, which is the bird flu. Here's what we found. There were 71 studies. First of all, we included only studies that would let us calculate rates or reported rates. So rates being people who exceeded a cutoff from normal on a particular measure of stress or depression. Most of the 71 studies focus on the 2003 SARS epidemic. There were 33 studies, and then less than 10 each focused on Ebola, MERS, H1N1, H7N7, and does it say H1N1? Yeah. Okay. And the other thing to note is that majority were cross-sectional online surveys of people. We could only identify one population study of mental health in older adults 1 year after SARS, so not during SARS. Although there are reports of 30% increase in suicide rate in Hong Kong during SARS, but these were not based on population, so we didn't include that in our review. So what we did was we collated all of the findings. I'm just trying to get my video out of the way. Okay, so what we did was we took all the measures and we summarized them according to 6 main symptoms, which seem to be measured across all studies, across many pandemics. So post-traumatic stress, or PTSS, depression, anxiety, stress, insomnia, and then psychological distress or emotional distress, which didn't seem to fit specifically into any other categories. So I'll be using this kind of table again and again, so I hope it's clear for you. So we then pooled the sample sizes across all studies. Again, it's across all pandemics. And we then calculated a rate of people who exceeded a certain number. Let me minimize, sorry. Okay. So you can see that, and I've drafted for you. So at the bottom, you can see that about 31% of the general population report symptoms that are clinically significant post-traumatic stress symptoms. 20% report depression, 26% report anxiety, 30% report stress. A smaller number, 20%, are reporting sleep disturbance, and then about a third report psychological distress. If we collapse all the symptoms together, then we can say that in the general non-geriatric adult population, more than 1/4 or 26.8%, experienced depression, anxiety, stress, insomnia, or psychological distress during previous pandemics like SARS, Ebola, MERS, H1N1, H7N7. But as I said, there were actually no studies focused on older adults. So the impact of past pandemics on older adults' mental health is not clear. So let me turn to the second objective. So to discuss the literature on mental health outcomes of older adults during the COVID-19 pandemic in Canada and globally. So we actually, I wanted to just provide some context, and maybe you've heard this over and again, but for me, this whole year and a half has been a blur. So let me just make sure we have some context here. So as we all know, the first case of COVID-19 was confirmed in January 2020. There was a state of emergency declared in March 2020. In July, that was lifted. The summer was going pretty well. But in September 2020 came the second wave of the pandemic. Fortunately, vaccines were approved in December of 2020. But then there was this province-wide shutdown in Ontario on December 26th. January 12th of this year, there was a second state of emergency declared with a stay-at-home order that was lifted about a month later. Those orders were phased out regionally in March. It was the third wave of the pandemic. With a province-wide shutdown in April and a third state of emergency stay-at-home order in early April, which stayed until about 6 weeks and resolved in May 2021. The summer has been looking good, but now, of course, as we all know, in September, we're in the fourth wave of the pandemic, and people called it pandemic of the unvaccinated, because it's mostly people who are not vaccinated who are ending up very ill and in the ICU. So that takes us to the present. Okay, we began again first by looking at the literature. So this work was done by Srina Thapar. She was a University of Toronto summer student in my lab just for 3 months, from June to August 2020. And so we looked at the literature in the first 6 months of the pandemic, whatever was coming out, to look at what are the rates of depression, stress, and other psychiatric or psychological symptoms in the general population. If we could, we wanted to look, of course, specifically at older adults. We included any studies that had validated measures to assess psychological or psychiatric symptoms. The majority of the sample had to be of the general population, so we were not focused on healthcare workers or patients who were infected with COVID-19, since they would come with their own symptoms due to direct infection. We need to be able to compute rates of people who exceeded the cutoff for normal on the measures or had to be reported. Because it was very early on, we did include preprints as well as published studies between January 1st, 2020 and June 1st, 2020. And the key terms were COVID-19, SARS-CoV-2, coronavirus, and mental health or psychological or psychiatric. We found 50 studies, 23 were preprint. All of them were cross-sectional online surveys. There's a big range in sample sizes, from as small as 148 to as large as 52,000. And the mean sample size across studies is around 3,100. The mean age across studies is 36. There are only 2 studies we found that looked at older adults with fairly small sample size. This is again in the first 6 months of the pandemic. And the ranges were very variable. So as small as 18% to as high as 40%. So very hard to conclude anything. In addition, in almost half of studies, the proportion of older adults, 65 and older, was not even reported. But of studies that did report the age distribution, we could see that the average proportion of participants who were 65 years and older was less than 5% of samples. Here's what we found. So again, we've summarized all the findings and compiled them into 6 main symptoms: post-traumatic stress symptoms, or PTSS, depression, anxiety, stress, insomnia, psychological distress. You can see the number of studies that reported on those kind of symptoms, the sample sizes. We pooled sample size across all studies to get a, we call it a prevalence rate. And here, again, this is mostly in 1865, because older adults were not really represented in the samples. But you can see about 33% of the general population were reporting post-traumatic stress symptoms in the first 6 months of the COVID-19 pandemic. About 30% reported depression, 28% reported anxiety, 30% reported stress, smaller number, 16% reported insomnia, and 29% reported general psychological distress. So in summary, within the general non-geriatric adult population, more than 1/4, or 27.6%, experienced depression, anxiety, stress, insomnia, or psychological stress during the first 6 months of the COVID-19 pandemic. Okay, but what about older adults? So we looked at this more recently because by a year later, there are many more studies in older adults. This work was led by Amanda Ramadian, she's a research analyst in my lab, and Simi Jasal, she's a third-year University of Toronto co-op student, and both of them just started working in my lab in September 2021, so just like 6 weeks ago. We did a literature search to look at what are the rates of depression, stress, and other psychiatric or psychological symptoms in older adults, and we used the same criteria. They had to report rates, so people who exceeded cutoff from normal on measures. We were looking at the general population. We were interested in frontline healthcare workers or people infected with COVID. And we started the search from January 1st, 2020 up to October 21st, 2021. There were 38 studies that were published, and the majority were cross-sectional online surveys. There were 12 that used phone surveys. 1 used video calling. There's a range of sample sizes as small as 55 up to as high as 7,100, and the mean sample size across studies was 1424. So you can see that's about less than half of the previous work in general population. The mean age across studies was 72. There are actually only 1 study based in Canada and 1 based on a US-Canada sample. So we've just compiled them all together into 1 group, although there are obviously limitations for doing that. In any case, here's a table again. So again, the 6 symptoms, PTSS, depression, anxiety, stress, insomnia, and psychological distress. You can see here, so again, this is older adults only, and this is during the COVID-19 pandemic. So 28% of older adults are reporting post-traumatic stress symptoms that are clinically important. 25% report depression, 21% report anxiety, about 12% report stress, 44% are reporting sleep disturbance, and 24% are reporting psychological distress. In conclusion from this work, within the general older adult population, we can say that more than 1/4, or 25.6%, are experiencing something. So whether it's depression, anxiety, stress, insomnia, or psychological stress during the COVID-19 pandemic. And I just wanted to compare, it's not a exact comparison, but just to give some context to those numbers. So here I'm showing the figures for the general population, so 18 to 65 in blue, and then older adults in yellow. And you can see what's striking is that for insomnia, older adults are reporting much higher rates compared to the general population, 18 to 65. And then everywhere else, they seem to be reporting less stress, depression, anxiety, post-traumatic stress, and distress overall. Here's the overall figure across all symptoms. And older adults, it's fairly similar. So for the general population, again, it was 27%, and here it's about 25% for older adults. All right, so now I'm gonna, and I'll have more to say about that, but I want to move on to the third objective. So now I'd like to talk about some recent findings on a study that we've been doing, where we looked at changes in mental health in older adults over the course of the COVID-19 pandemic, and to look at the effect on both subjective and objective cognitive ability. Okay, the study is called COVID-19, Risk to Mental Health in Seniors, or CRIM study. This is a study I'm leading with my collaborator, Benoit Masson at CAMH in Toronto. So in terms of study rationale, I think we all know these points, but just to reiterate, we knew at the beginning of the pandemic that older adults were at greater risk for severe illness and fatality. We also know that they're vulnerable to mental and physical health risks as a consequence of public health restrictions that lead to increased social isolation. There's a very extensive literature showing that loneliness and being isolated socially are risk factors for medical illness, for increased morbidity as well, and relevant to my field that these factors also increase risk of dementia. I think everyone in the mental health field knows that social isolation and loneliness is also strongly associated with depression, anxiety, self-harm, and suicide attempts. In Canada, nearly 1/4 of adults aged 65 and older live alone. And so we expected that the health effects of prolonged physical distancing and voluntary home quarantine might be particularly adverse in seniors. However, we also recognize that here we had a natural experiment. So I mentioned at the beginning that my research actually looks at risk factors for dementia, and we're studying a lot of older adults who are at risk for dementia due to things like a past history of depression, mild cognitive impairment, which is a precursor to Alzheimer's, or subjective cognitive decline, which describes people who think they have memory problems or cognitive decline, but when you test them, they test normal. So here was an opportunity to look at how people experiencing stress and depression during the pandemic how it might be affecting their cognitive abilities. These are the aims for our CRIM study, and one was to look at changes in psychiatric symptoms and incidents of new onset or relapse of mental health conditions during COVID-19 in older adults with normal cognition or underlying mood or memory conditions. The second aim was to identify risks and protective factors for these mental health outcomes. We had some secondary aims. One was to look at the impact of stress and depression on subjective and objective cognition in older adults. And also we wanted to look at how feasible was it for older adults to monitor their mental health using online survey tools. So, but for today's talk, because we just actually got the database cleaned up in the last week and the data analyzed in the last few days, I'm going to be just focusing on these aspects. So talking about changes in psychiatric symptoms over the course of the pandemic, to look at a couple of risk factors that seem to increase adverse mental health outcomes in our group, and then to just talk about some very early findings where we looked at how stress and depression might be affecting cognition, both subjective and objective, in our sample. So in terms of the study design, this is a longitudinal study. We did virtual sessions by Zoom or telephone if the person didn't have internet. Caregiver, so a spouse or a family member or partner, to look at mood, stress, and other psychosocial variables at 3 time points: baseline or T0, at 3-month follow-up, and then at 6-month follow-up. And those assessments took about 1.5 to 2 hours. In addition, we sent people online surveys with the same or very similar questionnaires at monthly intervals between those time points. So at 1 month follow-up, 2 months, 4 months, and 5 months, or we sent it by mail for people who didn't have internet access. There are a lot of summer students, co-op students, and research analysts who've helped with the study. Christy Ayung was a summer student who learned REDCap on her own and created the surveys and recruited and administered surveys. Joyce Lowe also helped create surveys and created a database, as well as recruiting and assessing people. And then a whole bunch of students were helping with doing the actual Zoom or telephone assessments, including Serena Thapar, a summer student. There were 2 master students, Jeffrey and Nasdar. There's a co-op student, Sangeetha, I'm not going to say her last name, and then a whole bunch of research analysts at other sites involved in the study. So again, I'm going to reiterate, this is not a population-based study. It wasn't random. We recruited people who were already in existing studies, so it's a multi-site study. Older adults had to already be in a study at one of the U of T teaching hospitals, so Center for Addiction and Mental Health, University Health Network, Sunnybrook, or St. Michael's Hospital. They were invited to be a participant in the CRIM study. Partly there were practical reasons, but also we knew that we had pre-pandemic data on mental status and cognition, including extensive neuropsychological assessment. So we knew that we'd be able to look at pre and post or peri-pandemic changes. we started enrolling people from April 2020, and it's still ongoing. Entry into the study is limited mostly because of our extensive assessments which are frequent, and not having enough study personnel. So we are still enrolling people even at this late date. There's a range of diagnoses. Some older adults have remitted major depressive disorder, or RMDD, which means they've had depression in the past, but now they're recovered, so they don't have a clinical diagnosis of MDD at the moment. Some have mild cognitive impairment, or MCI, which I think all of you know is memory impairment, but the ability to function independently in everyday life. So this is not dementia. And then we had a larger group of cognitively unimpaired people who did not have any depression or any other psychiatric history. The measures we selected were based on our literature. So what had been done in previous studies of mental health outcomes during pandemics. They had to be reliable and valid, of course. They had to be pretty easy to administer in older adults. And also we used some measures that had been used in the parent studies where the older adults were drawn from. So we could do some pre-post comparisons. Some of the measures were self-report, and some of the measures were informant-based. So that would involve a family member, like a spouse or a child or a partner. This is just some of the measures. We use the perceived stress scale. That's a 10-item measure of stress that's been used extensively in pandemic literature and mental health outcomes. The impact of event scale revised, or ISR, is a 22-item measure of subjective distress caused by a traumatic event. It's been used to screen for post-traumatic stress disorder, or PTSD, and here studies use it to characterize post-traumatic stress symptoms. For depression, we use the Patient Health Questionnaire, or PHQ-9. It's a 9-item measure of depression. It's used in clinical trials and even in the clinics, and it's been used a lot in the pandemic literature, so we included that. We also added later a scale called Cobus stress scales. I'm not going to be talking about that today, but just so you know that we also were interested in looking at anxiety and stress specific to COVID-19. For example, fears of becoming infected or contamination. This is a list of a whole bunch of other measures that I'm not going to be talking about, but just want you to be aware that we have other, it's going to be a very rich database to try to look at what are contributors to stress and depression in this cohort. Some of them are looking at loneliness, social connectedness, coping strategies, resilience ability. We also developed a questionnaire just to look at people's knowledge about SARS-CoV-2 and how compliant they are with public health measures. The one I will be talking about is this last item. It's called the Memory Function Questionnaire. This is a measure that asks people to assess their own memory ability. So it's a perception of memory ability, or subjective memory. And we created a 5-item version from the original, I think, 45-item, just for brevity, because we wanted to minimize subject burden. And so this measure, MFQ 5-item, is what we're using as a subjective memory outcome. We also administered 3 measures that were administered to the informant. And I won't talk about these either, except for the middle one, the Clinical Dementia Rating Scale, sum of boxes. So anyone who does research in Alzheimer's and dementia or mild cognitive impairment is familiar with the scale, the CDR. We're using it as an objective measure of cognitive status. The higher the score, the more cognitive impairment. We use it partly because it's short and because it was included in all of our other studies, so we can then look at pre and post changes. The other 2 measures, neuropsychiatric inventory and functional activities questionnaire, I won't be talking about today, but we included them because they're a part of our parent studies, and we can also look at impact on everyday functioning. So for today, as I said, we just cleaned up our database at Baycrest in the last week, and these are early findings. So I'll be talking only about data from the Baycrest site, so where I'm working, and we have 107 participants, so we're not including participants from UHN, CAMH, Sunnybrook, or St. Michael's Hospital. So again, these are very early findings. In terms of demographics, so this is 107 participants in our sample. there were more women than men. That's pretty typical of studies of older adults and aging. So almost 2/3 were female compared to about 1/3 were male. The mean age was 71. The majority were married or were living with a partner, so 64% were in that situation, and the remaining were separated, divorced, and then mostly widowed. The race, unfortunately, is a 90% Caucasian sample, so I think there's some limitations to this data, but yeah, that's also a fairly standard issue in aging research. In terms of education, this is a fairly well-educated group, with most finishing at least a bachelor's degree. So there's a mean of 17 years of education. In terms of diagnosis, almost 2/3 were cognitively unimpaired and had no history of depression or any other psychiatric illness, so a healthy group in 64%. 14% of the sample had mild cognitive impairment, and then 22% had a past history of depression, not current, but somewhere in the past. With and without mild cognitive impairment, I just collapsed them just for ease of reporting. Okay, so first I'll talk about changes in incidence of psychiatric symptoms in this study. And I'll be focusing on these 3 measures. So again, the perceived stress scale, a measure of general stress, the IESR, which measures or characterizes post-traumatic stress symptoms, and the PHQ-9, which looks at depression. This is a graph showing results over 3 time points for the perceived stress scale. So I'll just walk you through it. On the left, those are assessments done at baseline or at study entry, so the 107 people. And then in the middle, those are assessments done 3 months later or 3-month follow-up. And then on the far right are assessments done at 6-month follow-up. You can see we don't have a full sample because some people are still undergoing their follow-up. In the blue bars are low stress or normal. So these are people who report within a normal limit of stress on the perceived stress scale. Yellow is moderate stress and green is high stress. So what can we say overall? If just looking at the graph in its entirety, about 35% of participants are reporting moderate to high stress at baseline. When you look over time, it looks like the self-reported stress is fairly stable over the 6-month period. People are not reporting more or less stress over 6 months. And then this is the impact of event scale revised, or ISER, which assesses post-traumatic stress symptoms. So again, this is a graph showing 3 time points. At the far left, those are our assessments at baseline with our 107 participants. In the middle is the 3-month follow-up, and then at the far right is the 6-month follow-up. The blue bar means that they scored within normal. The yellow is suggests partial PTSD, or you can think of it as clinically significant post-traumatic stress symptoms. Green suggests it could be probable PTSD, and red suggests severe PTSD. Of course, these are just a screening tool, so that would have to be corroborated with a diagnostic assessment, but that's what those cutoffs would suggest. Overall, we can say that 38% of participants report clinically significant post-traumatic stress symptoms, and I would say there's minimal variation over the 6-month period. Okay, and then finally, this is the depression measure, patient health questionnaire. So the exact same format as before. So we're showing baseline, 3-month follow-up, and 6-month follow-up. Blue is normal, meaning minimal depression. Yellow is mild depression. The green is moderate depression. The red is moderately severe. And then the darker blue, which is only present in 1 person at baseline, means severe depression. So if we look at overall, we could say that 34% of participants are reporting at least mild depression symptoms at baseline, so at least yellow or higher. And to me, the scores, and this is just a visual inspection, but the scores look stable, possibly a slight increase over the 6-month period. I haven't run the stats, though. So here, then what I want to do is just put our findings into context based on what we already knew from the literature. older adults. So these are the same numbers I showed you earlier. I just put them all onto the same graph. In blue, those are stress, the percentage of people in the general population, 18 to 65, who scored above the cutoff for normal. In blue for stress and post-traumatic stress and depression. And yellow is the older adult population, and green are the scores that I just reported to you just now. So if we just compare the literature in older adults, so yellow versus the green, you can see that the rates we're seeing are higher. We're seeing more stress, higher post-traumatic stress, and higher depression. They're really more comparable to the general population. And of course, our studies are different. So most of the studies that are done in older adults are these anonymous online surveys at one point in time. Here we're doing face-to-face Zoom assessments. The sample are participants who are already in our studies, with some with mood and cognitive conditions. So I don't think we really can compare, but I just wanted to provide context that we're seeing higher rates than the literature. We have to understand why, and we'll be doing more analysis and follow-up to understand that. Okay, now I'm just going to talk very briefly about some risk factors. If I had time, I would have liked to look at the loneliness data, social network connections, all of that to understand risk factors. But for today, I'm just going to focus on two very simple ones, just demographics. So gender and diagnosis. And I think most of you can probably figure out what we probably found. So looking at men versus women across the entire sample, so across the 107 people, as expected, we found that so women are in the yellow and men are in the blue. Women are reporting higher rates of post-traumatic stress, general stress, and depression compared to men. That's not very surprising. That's consistent with the entire literature on mental health. And then when we looked at diagnosis, so what was the effect of having either diagnosis of mild cognitive impairment or past history of depression in the past, we could see that older adults who had admitted depression were reporting higher rates of depression symptoms, post-traumatic stress symptoms, as well as general stress. What was interesting is that even in the mild cognitive impairment group, so on the far left, this is perceived stress scale, the green bar, that older adults with MCI also are reporting more stress compared to people who are cognitively unimpaired and who are healthy. Okay, and then for the last part, I'm going to talk about just some very early findings. I just ran these analyses to see how is stress and depression at various time points affecting future subjective and objective cognition in our sample. Okay, so here, what I did was I looked at the various scores for the measures, perceived stress scale, the ISR, and the patient health questionnaire at one time point, and then I asked whether that would predict 3 months later subjective or objective cognitive status. So this graph is showing the perceived stress scale, or a general stress measure at time point 3 or 3-month follow-up, and its relationship to how good people thought their memory was at T6 or at 6-month follow-up, i.e. 3 months later. So you can see, I hope, that there's an inverse relationship. So the more stress people were perceiving at 3 months, the worse they thought their memory was at would think their memory was at 6 months. When we did a linear regression model, including diagnosis, gender, age, and depression, we found that PSS raw scores, so these stress scores, did significantly predict subjective memory ability at the 6-month follow-up. And that was controlling for depression. In contrast, post-traumatic stress wasn't predictive, and neither was depression. Then when we turned to look at objective cognition as measured by the clinical dementia rating scale, we found a similar picture, but this time with depression. So depression scores at the 3-month time point could predict objective cognitive ability at the 6-month follow-up. And that's after controlling again for diagnosis, gender, and age, as well as controlling for stress. So these are intriguing findings. So it's not a huge sample, so I don't think we can be conclusive, but I think it's intriguing to see that there could be acute effects of stress and depression 3 months later on both subjective and objective cognitive ability, and we'll be following up on this with a larger sample. Okay, so what study conclusions can we make based on these early findings? So first of all, in this non-random and relatively small sample, older adults, we're seeing higher rates of depression and stress compared to rates that are reported in the literature in older adults during the COVID-19 pandemic. We see that women have higher adverse mental health outcomes compared to men, which is not surprising. The older adults with a past history of depression have higher rates of depression, general stress, and post-traumatic stress symptoms compared to healthy, cognitively unimpaired, and older adults without any psychiatric illness at all. It's a little surprising for us that older adults with mild cognitive impairment, which you know is a prodrome or precursor to Alzheimer's disease, also had higher rates of stress, general stress, compared to the healthy, cognitively unimpaired group. And then, as I just said, we're finding that general stress levels across the entire sample can predict subjective memory or perception and memory ability 3 months later, independent of age, gender, diagnosis, or depression symptoms. And in contrast, when we look at objective cognitive status, that it's depression symptoms across the sample that seem to predict objective cognitive ability 3 months later, independent again of age, gender, diagnosis, or stress level. All right, so these were the learning objectives that I was hoping to cover today. And here are the take-home messages based on those objectives. So the impact of previous pandemics like SARS, MERS, H1N1 on older adults' mental health is not known because they just weren't studied. However, in the general non-geriatric population, about a quarter or 26.8% experience adverse mental health outcomes such as depression, insomnia, or sleep or stress during these past pandemics. When we look at the literature on COVID-19, it's actually a very similar number, a similar approximate 1/4 of the general adult population, or 27.6%, and also older adult population, so 25.6%, have experienced adverse mental health outcomes during the COVID-19 pandemic globally. In my opinion, I think older adults are underrepresented in the studies of past pandemics as well as COVID-19 because they've relied mostly on these anonymous online survey methods. We know about the digital divide, that older adults often don't have access to devices or are not familiar with using technologies. I suspect, based partly on our data, that rates of adverse mental health outcomes during COVID-19 in older adults are maybe higher than what's being published. I think there's a need to assess older adults' mental health using alternative means such as phone surveys or texting surveys, or we have to facilitate access to online and assist with technology so that they can be a part of the research, so we can get a true picture of what's happening to older adults' mental health during the pandemic. Pre-existing mood and cognitive conditions, as well as gender, appear to be risk factors for adverse mental health outcomes in older adults during COVID-19. I think that we have a signal that stress and depression during the COVID-19 pandemic may have acute effects on both subjective and objective cognitive ability. I'm just being cautious because this is only one sample at our site, and it was 107 people only. But I think these findings definitely warrant further study because it suggests that if it's true that there can be acute effects, then we should definitely be intervening to address depression and stress during the pandemic in older adults. I'd like to acknowledge my collaborators, Benoit Masson at CAMH, Nathan Hearn at Sunnybrook, Krista Lanko at Sunnybrook, Alistair Flint, who's at University Health Network, Corinne Fisher, who's at St. Michael's Hospital. I said there were many research and analysts and trainees involved. Christia Young, who's now graduate school in clinical psychology. Joyce Lowe, who's a co-op student, now she's in her last year undergrad. Serena Thapar, who's a summer student, now she's in graduate school in psychology. Jeffrey Yu, who's still a master's student. Nazar Sadek, also a master's student. Sankitha, who's still a student in my lab. Oh, and I should say Amanda Ramayan, who's still a research analyst in my lab. And Simi Jasal, who's still a co-op student in my lab. The funding for the study is being provided by the Ontario Ministry of Health AFP Innovation Funds. With that, I'd like to thank you for your attention and happy to take any questions or comments.
Thank you.